Teşekkürler Sayın Başkan.
Thank you, Chairman. In this speech, I'm going to talk about the polisomnography findings in PTSD. Of course, when we say polisomnography, we are talking about an integrated analysis where the sleep is analyzed. In polisomnography, the EMG, the cardiac activity, respiratory activity, many activities are analyzed at the same time. And about sleep, the stages of sleep are investigated. So I will try to summarize these findings in the PTSD patients. Here we can see the alpha activity is very intense. And this is a wake record, by the way. And this is the stage 1. There are a couple of epochs. And during the sleep, we score this sleep period very rarely. Here we have the slow eye movements as the SEM, you can see. They are very typical for this period, for this stage. And in the EEG activity, the frequency is slowed down a little bit. And in the EMG activity, in the bottom, we have quite a high intensity. For stage 2, this is a stage that we can score very intensely. Approximately 60 or 70% of the stage is of the sleep is stage 2. And we have the typical electrophysiological changes, like we have the K complex, and we have the sleep spindle, as we call it. In stage 3, we have the intensive delta activity. This is also called as the slow wave sleep. This is the deep sleep, actually. And according to the new classification, we don't have stage 4. So if the delta activity is more than 20%, then we score it as stage 3. REM sleep is a specific period in sleep, particularly it is related to the formation of the memory, where we have the basic function of the formation of the memory activity. The system is closed down and the memory is shaped. Here we have rapid eye movements, as you can see here. And rapid eye movements are seen, and also in the EMG, in the bottom line, there is atony. So there is loss of activity in the EMG. And also we have the complicated wave activity close to wake. And this is also typical rapid eye movements. You can see right and left eye movements at the bottom. And in the EEG, we have a period that is a manifestation that is close to wake period. In the PTSD, as mentioned before, there are 2 basic symptoms. First, we have the insomnia at the beginning, falling asleep, and for maintenance. And also there are nightmare disorders related to the trauma. About the maintenance, about the sustainability of the sleep, there are so many data. We are going to talk about them mostly. The sleep latency, effectiveness of the sleep, the total sleep time, and also the duration and a number of the wake periods. The REM percentage, latency, intensity, and interruption number and percentage are also important parameters. When we say REM latency, it is the period when we have the first period until we see the first REM activity. In post-traumatic stress disorder, we have the longer sleep latency, the number of the wake-up periods and the duration of the wake period is increasing. And also about the REM, we have different data because the depression comorbidity is seen very frequently in these patients. Therefore, we have different correlations with REM. But in general, the REM intensity is increasing in these patients. However, more consistently, the REM is interrupted, being related to the nightmares. The person wakes up, or suddenly the person goes back to stage 1. Quite frequently. This is a study conducted at our clinic. We have 24 PTSD patients, and the total sleep period is decreasing, sleep efficiency is decreasing, sleep latency is prolonged in the PTSD group, and stage 3 and 4, I mean the deep sleep period, is decreasing very clearly, and REM latency is also short in the PTSD group. This is probably related to comorbidity. What are the signs? What can we understand from these findings? The decrease in the deep sleep period, or increase in superficial sleep, or the increase in number of wake-up periods show that there is an overstimulation, and the heart rate increases, etc. And according to the studies carried out, there is the decreased nocturnal growth hormone secretion that is related to that situation. Increase in REM intensity is not very consistent with the other findings, but mostly this is related to traumatic memory. And also the distortion of the continuity of REM, or switching from REM to stage 1 and wake-up period, these are related to the nightmares that are related to the trauma. We have a hypnogram. We check how a person sleeps throughout one night during our polisomnografi study. So this is a chart showing the sleep pattern of a person. Normally, we have cycles of sleep, of course. Stage 1, stage 2, REM, and the deep stage, and REM, and this is one cycle. So we complete our sleep in about 3 or 4 cycles a night. And in the first stages, in the first half of the night, we have the deep sleep, and towards in the second half of the night, the REMs are seen more frequently. Here you can see switching from REM to stage 1 or to wake up can happen only 1 or 2 times, and you can see the micro stimulation, leg activity, or endogenous factors may cause this few number of waking ups. But when we look at the PTSD patients, the switchings from REM to stage 1 is more frequent. And there is another point that the REM is seen much earlier, and REM latency is also shortened a little bit. Of course, there is comorbidity of depression, and it also explains the shortened REM latency. Polisomnography studies results may be contradictory to the post-traumatic stress syndrome because the patients may still be on some drugs, some medications. Sleep apnea and periodic leg movements might be more frequent in the PTSD groups compared to the control group. These are also changing the sleep structure, and also the sample sizes are also different among the studies. That's why the results are contradictory. What are the comorbidities in PTSD polysomnography? We have the mostly major depression and other comorbidities that are seen. We have seen that REM latency is short in the patient group. But in this PTSD group, we can see that it is no different than the control group. But if there is the comorbidity of depression, then REM latency is shortened. Therefore, it's affected. And there are some variables which are depending on the age. Normally, together with age, the deep sleep stage and REM sleep are decreasing. However, in the PTSD, the REM sleep is increasing, or that decrease according to age does not take place. And also, in young patients, young cases, there might be problems about the continuity of the sleep, and total sleep period is shortened. When it comes to the gender, men are less lucky. Let's say, because sleep disorders are seen more frequently in men if they have PTSD. It's of course related, it may be related to the type of the trauma that they face, because conflict, aggression, if there's PTSD after a conflict, may have affected the results. And also age-related changes are more apparent in men. As a result, in PTSD, sleep symptoms are related to the clinical symptoms and clinical symptom severity, and also if these symptoms are present in the patients, then they may affect the quality of life of the patients negatively. Therefore, they should be treated carefully. In April, I hope that we'll see each other again. Thank you.